So I would just like to introduce myself to those of you who don't know me. My name is LJ Shipley. I'm a pediatrician on the leadership team at Galveston Children's Hospital and one of the associate medical directors at Accountable Health Partners focused on maternal and child health. I'd like to just start by welcoming you all on this call. Now we've got primary care providers and practice teams and child health leaders and community-based organizations from around the Finger Lakes region. And I just want to thank you for giving up your evening time for this important call. And we're really going to do our second regional discussion about return to school. And this really is a collaboration between Galveston Children's Hospital and University of Rochester Medical Center, Rochester Regional Health, GRIPA, AHP, the Monroe County Department of Public Health, and the Monroe County Medical Society. And I just want to thank all of those systems that are collaborating on behalf of our kids in our region. So I'm going to give sort of level setting for a moment. At the beginning of the pandemic, as you all know, we all came together to try to figure out strategies and ways to approach the care and concern for our kids in a way that would protect them. And so right now we're in a similar state where we want to try to have as much clear communication, uniform approaches as we possibly can in order to support the return to school safely for our kids. So for this call, the agenda that we're going to cover is briefly updating you on current New York State Department of Health guidelines and the related Monroe County Department of Health protocols. We will touch base on symptom screening that will happen in schools and at home for children. And we'll talk about the need for COVID testing, the role of the Department of Health for COVID positive cases, isolation, contact tracing, and quarantine, and what the requirements and documentation are for return to school. And then we're going to talk in a little more detail about COVID testing, both in terms of what is acceptable and how you can either do or send for testing. We're going to talk about masking tolerance guidance, the New York State DOH requirements regarding vaccination that was just released. And then it's an open discussion with the expert panel. And we're fortunate to have with us today representatives from the Finger Lakes Reopening Schools Safely Task Force, the Monroe County Department of Health. Dr. Mendoza is with us on this call. University of Rochester Medical Center Infection Prevention, Brenda Tassini is on this call. And then colleagues from Developmental Behavioral Pediatrics. I know that Lynn Cole is on this call. I'm not sure, I don't think Susan Hyman is, but Lynn is. And then Monroe County Medical Society as well. So what I'm going to do is just in opening this, I'm going to try to go through a few slides just to level set what we know right now. And then I'm going to turn that conversation over a little bit to Dr. Mendoza for him to elaborate on that. So just as a reminder, all of you would have seen this guidance that came out from Monroe County Department of Public Health, specific to an algorithm of what happens for students who have symptoms that screen positive for COVID, whether at home or whether they are at school, and then what protocol kicks in. And so I think most of you have seen this. I'm going to highlight the aspects of it, but I want to make sure if you haven't seen it, you know that it exists out there. Whoops. So, sorry, I went a little fast with my screen there. So this is the summary. For a student who has screened positive for symptoms to return to school, according to the current New York State Department of Health guidelines, which is what our County Department of Health needs to go by and what we need to go by. Every kid will need to have some form of healthcare provider assessment. So either in person or telehealth. They will need to have a COVID NP swab sent for PCR. And we'll talk a little bit about what people might be able to do in that case, whether in their practice or referral. They will need documentation of the COVID test results sent to the parent or guardian. A positive COVID test starts the Monroe County Department of Public Health pathway. A negative COVID test starts the PCP pathway. So for COVID patients, COVID negative patients, excuse me, the parent guardian will need to contact the PCP office after you have seen them, after you have sent that positive test. They will need to contact you, or you'll need to contact them once that child is asymptomatic and fever-free for 24 hours. This is a really key point, and I know that people have lots of questions on this. Why can it not be that they've got a negative COVID test and they can go back to school once they're fever-free for 24 or 72 hours and their symptoms are improving? But the guidance from the Department of Health, from the New York State Department of Health, states specifically the child needs to be asymptomatic. So I just want to I know there's a lot of questions about that. Mike can speak to that even more, but that is what the guidance is that we have. We recognize that some patients may require follow-up calls or follow-up visits depending on their clinical presentation. But we do feel that since schools are relying on the parent reporting for COVID symptoms on a daily basis, that same should apply for this scenario, meaning that most kids would not require 2 visits to a healthcare provider in order to go back to school. We have some recommended language around a return to school attestation, which I will show you in a minute. But before I do that, I'm going to just skip ahead 2 slides and just want to point out this algorithm that you all will have received. This is the pathway that is followed if a child needs to be issued a quarantine order because of exposure. So I want you to know that those 2 documents are out there. They've been out there from the County Department of Health. Those 2 documents supersede any other guidance that was sent out in the last few weeks by schools. And I think all of you know that for a while there was a lot of different guidance that was coming out. And the reason for that is the guidance that comes from state ed, New York State Ed, and New York State Department of Health differ. But New York State Department of Health trumps in this case. So the last thing I want to show you on this, and then I'm going to ask people, I'm going to ask for some questions on this topic. If you can avoid too many questions about testing and stuff, we'll go on to that, but I think it's valuable for people to have an opportunity to ask some questions here. We are developing just a template, and we will send all of this stuff out tomorrow in a mass emailing as we did last week to update some things, but we are recommending that all of our practices, if possible, adopt a similar template or the same template for a return to school attestation. And the rationale for that is that's going to create far less questions coming from school nurses, far less confusion from families if we have the same thing. And so you'll see on here, I mean, this is basic stuff you guys know, but basically identifiers for the child and the school, that the child had a medical evaluation because of a positive COVID symptom screen, a symptom screen, not a positive COVID test, what the date of the healthcare provider assessment was, the date of the negative COVID test, and attestation based on the parent report that the child is now symptom-free and may return to in-person education. So I am going to actually stop sharing my screen for a second. At that point, we'll go back into the slides. And I just want to give people a moment. I'm sure there's a boatload of questions in the chat. And I'm going to ask Renee or Chad to work the chat a little bit and let us know those questions. And I wonder, Mike, would you like to comment on this aspect so far or entertain any questions from the team?
Yeah, sure. First, I want to thank you, LJ, for all of your work leading this effort. There has been a lot of confusion, a lot of different guidance. You all, as my colleagues, know that this is challenging and we are in a very challenging time. I will say that anticipating the first series of questions, which is why does a person have to have a negative test before going back, given that you all probably know your patients better than anybody else, that is something that we are working on changing. We have advocacy at the state, and I will say that I've heard it on multiple calls, most recently today at 3 o'clock with Dr. Zucker, that the intention is going to be to change the guidelines so that it does not require both a negative test and a healthcare provider documentation. It will be a negative test or documentation from a healthcare provider. So that is not yet official, but I would anticipate that that's going to happen. That being said, I don't honestly think that's going to change the demand for testing all that much, because ultimately it will require all of us to sign off on that letter. And unless it is very obvious that the person doesn't have COVID, my sense will be that many of us will still consider having those children tested anyway. So that being said, we are working very hard to expand testing. And so at U of R really is stepping forward, Rochester Regional also, to expand testing capacity. That's a work in progress. We hope to have more on that topic in the next week or so. but we are working to try to change the guidelines for return to school. The other one that we're working on changing is the insistence that the child be symptom-free. Given that a lot of people have chronic concerns, what we're trying to advocate for is symptom improvement. So that is something that we're working on too. That's not yet official. When that's official, we'll send it out. But what LJ has shared with you this evening is the current guidance. So for now, please go by what she has shared.
Thanks, Mike.
I've got quite a few questions in the chat, LJ.
Yep, I'm seeing them. So,
Okay.
So Mike, I'm going to ask you a few of these. It's just reclarification. So essentially, I think the concern that people are having again, one is, do these same protocols apply to childcare settings? And I would say that is not true. Is that right, Mike?
Right. This guidance applies for pre-K through 12. So for childcare settings, there has not been any official guidance. So that is something that we should work on.
There are protocols in the childcare settings that are usually determined by OCFS. Many of the childcare settings have been open and have been seeing kids. So, unfortunately, we really haven't seen a lot of increase in cases with that so far. The other question is I'm just picking a few out of here, guys, but one of our colleagues has said, I have no problem getting a test, but if it is negative, if you could reiterate again, why they need to be symptom-free. And I think, Mike, you just really answered that. We're advocating for that to change, right?
Yep.
Okay. So what if a parent refuses testing at this point?
So there are other counties that are grappling with this. Some counties have decided to go against the DOH guidelines and say that the child has to quarantine for 14 days. And in theory, that should be enough. But there hasn't been anything official in the DOH guidelines that allows that. So our current recommendation or policy is that the child must have a test. And I realize that that's problematic. We're working to clarify that because truthfully, if the child quarantines for 14 days, that should be equivalent. But there's nothing clear in the guidelines on that yet.
So there are a couple of notes in the chat about, what we could do in terms of having a common attestation form. We'll work on that, clean it up. I saw comments from Dave Sulo that are smart about what the EMR can actually populate. And for those of you who are on MedEnt, we can get that template done in MedEnt and be circulated. And I hope the same thing could happen for folks who are on Epic or other systems. There's a re-question again about would we expect that kids will need 2 visits? What we were saying in this is when you think about this, there might be some children who would require, you would want to see back to be able to evaluate them. But in general, we think that an initial assessment with the COVID test and then follow up with the parents, and whether you choose to do that follow up by phone or whether you choose to do that by televideo, I think that would be up to your practice. But in general, because you're just looking for them to achieve resolution of symptoms and parents are making that determination, right? Whether a kid is fever free, whether they are symptom free, they're doing that on a daily basis for their kids. I think we have to rely on that. The school needs to rely on that. Now, there's a whole bunch more questions in here. So there's a question about defining pre-K. So does that apply to official pre-K programs or to all preschools? So Dr. Tope was asking that question. I think, Dave, you're drawing the distinction between pre-K programs that operate out of CBOs versus pre-K programs that operate out of schools. And so in all honesty, we're looking at that, and a lot of those programs are looking at that, are assessing that right now. At this point, there's not specific recommendations around that. But for the pre-K programs operating out of the schools, some of the schools are adopting the same DOH guidance. This is not going to be a clear-cut thing. So, Chad, are you looking at this chat too? Because you can help me because I'm trying to.
Yeah, I can go through it because I'll just start reading some of the questions that have come up.
So I'd like to comment about urgent care and then ask the next one because there's a whole bunch of questions about urgent care. So we've heard from lots of you with a question about different questions about what if all of our patients go to urgent care, what will happen? So there's nothing in the documentation that, from my understanding and from talking to Dr. Mendoza, that specifies this has to be a PCP. but it needs to be a healthcare provider. So if your child from your practice did go to urgent care and was seen and had their test done, we should be able to get clarification around that so that it doesn't require another test for the family. I know from our colleagues in the independent urgent cares that they are very willing and feel they have capacity to be able to take on referral from practices, a referral just for the COVID test without the need to see a provider. Families would just see an RN, and they've already been doing that right now. So for some of you who do not have full testing capacity in your practice, and by that I just mean you have swabs and the ability to swab and put the swab in transport media, not to run tests in your practice. For those of you who have not stood that up yet or feel you might not have adequate supplies to do so, we seem to have the opportunity for two pathways. So testing could be done at the urgent care center on referral, or testing could be done in your practice. And I think our goal collectively is to not limit. We don't want to limit practitioners, primary care docs, from being able to see, evaluate, and test their kids. And so for those of you who are in the AHP network, we did a survey over the weekend just finding out how many of you are able and ready to test and what your experience has been. And close to 80% of those who responded said they are at this point set up to be able to do the NP swab. And I saw that was one of the questions. It is an NP swab. A nares or a mid-turbinate swab is not acceptable for symptomatic testing. It's different for asymptomatic testing, but it's not acceptable for symptomatic testing.
And LJ, this is Stephen. I just wanted to let everybody on with Rochester Regional and GRIPA know that we will have updates on the testing plan on Wednesday. So more to come.
Just going to pick on you for a second. Do you like to add anything about testing in the practices or just testing in general? What's acceptable? Comment on that?
I guess I would check using the term acceptable so much, but nasopharyngeal swab with a PCR test is the best, most sensitive specimen type do. So kids in our community safe. So that would be that's my standard. That's been our standard throughout URMC because it's the best combination of specimen type and test type to do. And I can only speak for the UR urgent care system will collect the specimen with the provider's order if that's not able to be done in your practice. So
I know that's true definitely for the two independent pediatric care centers, Pediatric Urgent Care of Rochester, as well as for acute kids, that they will do that on nursing order. I'm not sure about Rochester Regional's urgent cares at this point. Steve, are you able to comment on that, or is that something?
Yeah, I'm working on that, and we'll hopefully have some updated guidance. As of right now, it's a separate visit, but the team's working on that. So hopefully more updates to come.
Excellent. So I'm going to ask for a second while we're on this topic of testing and the fact that everyone needs testing. Lynn Cole has asked for thoughts from Karen Zandy and Ann Francis or others on children who have severe disability who would require potentially sedation to safely obtain testing. And Lynn, I would ask for you to feel free to comment in that space as well.
Yeah, I feel like I've thought a lot about masking and having high standards for kids regardless of disability for masking, but you know, there are kids for whom truly, like, even the most skilled person is not going to be able to get an NP swab without sedation. And I'm just wondering, I guess I was thinking that Karen and Anne may have thought this through in terms of their population includes many of these youngsters, and how to go about dealing with that. I mean, I think, Mike, your comment about, advocating for a 14-day quarantine being an acceptable alternative to testing would you know, help to solve that problem for those students. But otherwise, you know, I mean, otherwise I think we need to engage the sedation suite in their willingness or ability to do that.
It's kind of concerning to me about the length of time that would take.
Right.
And these are
Yeah.
the same parents. It is, and perhaps, Lynn, we can look at the cohort of kids that parents have opted to keep home for the first, you know, 10 weeks. But still, they're going to need some kind of evaluation. I don't know if another kind of test can be approved for them.
I think that's what we're going to need some help from Mike Mendoza to advocate for these kids, because I agree that there's a number of kids, Lynn, that can't handle even having the masks on, and we're going to need to have we may be able, if we can do anterior nasal swabs, if we can do saliva or something, we may be able to do it. But if we have to do the deep NPs, I think you're right. It's going to exclude this group of kids.
Yeah.
So we need help from Mike to have some exceptions.
And I think on a practical level, you know, there are going to have to be very individual case-by-case discussions for some kids as to what makes the most sense. And that's why I was kind of shying away from using the term, there's acceptable and unacceptable. There's the most sensitive, best combination, and there is, you know, gradations below that. You know, a mid-turbinate, certainly mid-turbinate swab, you lose a little bit of sensitivity compared to the nasopharyngeal. And so that's why, you know, I would say if we can get the best possible specimen, we need to get the best possible specimen. But are there situations when that's not possible? And I think based on what's going on with the child and how concerned you are as the provider, and what situation they're in, these are all things that will have to be discussed and thought about to figure out the best plan for that child, whether it's you know, a different type of specimen and or staying out of school for the time period as if they were positive. And these are things that I think we are going to have to work through together, certainly the first few.
I will say that in looking at the guidelines now, I don't think it specifies it's got to be a nasopharyngeal PCR test.
Yeah, the
Just as
state
diagnostic.
Yeah, the state guidance does not, as a community, we had kind of set that as our community standard.
And I think that makes sense in general, but I think that is an area where we might consider some exemptions as a community.
So Mike, the question about that, are you saying we might allow an exception on the NP versus a NARI swab? Or are you saying we might allow an exception on the type of test, PCR versus other? Because our understanding has been all along that only PCR testing is acceptable because of the lack of high enough sensitivity of the other tests, antigen or molecular.
Well, I think that's something where we have flexibility, and we could probably address that as a community, because I don't think the DOH guidance says anything specifically. So that's something we can talk about as a community. I don't want to handcuff us any more than we already are. So if we create a community standard that says that a certain type of diagnostic test is appropriate under these limited circumstances, you know, acknowledging for the difficulties in collecting NP swab in certain patients, I would be open to that.
So you're saying, I'm just clarifying because I'm sure people are thinking different things, since a lot of practices have been reaching out saying, hey, we're going to get the antigen test here and we'll do just our antigen testing here. I think what you're talking about is in this special population.
Yeah, the antigen test.
Exception.
Right, if the antigen test is positive, you can take that to the bank, but I think if it's negative, that's not adequate.
Right.
So.
Which is, so I just want to clarify, Brenda, if you want to talk about that, because that is something that continues to come up. People have mentioned the ID analyzer, people have mentioned a variety of other tests, and some may have already purchased or were ready to purchase and then understood that that really will not be acceptable in general. Do you want to comment on that?
Yeah, and this is, you know, continues to be an evolving, evolving aspect of the diagnosis of COVID, but currently the available antigen tests are really all at around 80% sensitivity compared to PCR. And certainly CMS has declared that that's unacceptable. And there's widespread recommendation, unacceptable, a negative test would be unacceptable for diagnostic purposes, that the test really needs to meet 95% sensitivity compared to PCR, to not have to be followed up by a PCR to confirm that negative diagnostic test. So with CMS stating that, that's why, most people and, certainly URMC and then groups that have been working on this for our community have really felt that that also is not acceptable for our community to put kids back into school with just the negative antigen test.
But for example, if we had 3 negative antigen tests separated by 2 days apiece, the collective sensitivity of that might be higher. So, I think we should talk about it, because otherwise these kids can't go back to school, right? And that's not fair.
I don't know if we're at a point where we know that we can't handle the volume. I mean, for me, the antigen versus PCR test is the volume, the capacity we have to test, right? So if we run up against, I think those are 2 separate issues. It's, for an individual child, what specimen can you actually collect? I think a specimen is better than no specimen, and most people would think that. But if we have access to PCR testing in our community, why would we not use that?
Right.
So there are lots of questions in the chat about that fact. Like, if we're trying to flatten the curve, isn't that 80% sensitivity enough? So what I'm hearing you guys say is maybe at the moment, not right now, but if our rates increased where you were more likely to be picking up that many more positives, there might be a reasonable indication to consider that, but we're not there right now. Am I right? I just want to be clear for the practices, because this is definitely something, nobody wants to be swabbing kids, getting a rare positive and then having to double swab a child and then send it for PCR too. I think that's not in the best interest of the kids at this point. Yeah. We're going to need to see just how much testing we really are doing and track and follow, right? This is a bit of an evolving story. And you can tell even from Dr. Mendoza's earlier comments, as of this morning, we understood there was going to be no change in that guidance. Now there might be some change in this guidance. So it's like we're playing a card game. And I think we got dealt a really crappy hand, but we're going to have to make the most of it. And hopefully it's going to change as we go on. And we just need to be as uniform as we can and share information and share ideas as best we can as a broad community. Like, I don't think there's a lot of other communities around the country where the primary care practices from all over the place, from the region and from different systems, are coming together to try to think about this and to advocate for kids and to come together with the schools. And so I think, like, already, maybe we have more of a winning hand, or we have a winning team in this game, and we have to take advantage of that. So there's lots of stuff. I have to just say, I think I'm going to have a seizure because I cannot keep up with reading what's going on in the chat. So if there's something in there, I'm going to rely on Chad. If there's something in there we really need to pull out right now, a particular conversation, I would welcome that from Chad. You guys are fast and furious in your typing.
Yeah, I think a lot of the questions are repeats of questions that have been answered or addressed. So if we're not addressing the question, it's not because we're trying to ignore you. It's just, it's hard to provide the answers repeatedly. So a lot of them are slight derivations on former questions to some degree.
We want to have, maybe want to have the urgent cares, because they're making some responses in here of what they're willing to, acute care kids and I think clinical.
It's
pediatric
urgent care. It's pediatric urgent care of Rochester and acute kids. And I don't know if there's lots of questions about what. I think we've already verified that they will do a test without an assessment if you've referred them, if you've done the assessment on the child. And then there's a lot of questions about cost and what the cost share would be for a family, or what cost would be to a family without insurance. I understand that the urgent cares do bill to insurance. So I don't know if Kathy Grisanti, are you still on the call? Do you want to speak to that from Pediatric Urgent Care of Rochester, and then we can give acute kids a moment to speak?
Yes, I'm on the call. So we have the capacity to do a nurse visit and it is run through their insurance. There's no copay. If they have no insurance, we just charge a $25 lab draw fee. We are happy to see any patients who require them, but if the patient does not require an exam and the primary care doctor wants to fax over a copy of the script, our nurse will obtain the swab and send it off and have the results sent directly to the primary care providers.
Thank you, Kathy, for that. And then Krista, I'm assuming that you're on?
Yeah. Hi, everyone. Thanks for having us. We do exactly the same thing. We're very happy to see kids both for evaluation and testing, or just straight testing. We just want to really make sure that children aren't falling through the cracks, that they don't just drive up parents asking for a test without an evaluation somewhere. So we really want to make sure that we're developing that partnership with primary care providers to make sure that all the kids are getting an exam at some point.
And I know we don't have UR Urgent Cares on, but Brenda, you commented that the UR Urgent Cares, will do the same thing. An order from a physician or from a primary care provider. Apologize to all the nurse practitioners and PAs on the call that I said that. That they will do that test with a nurse visit, correct?
Yeah, exactly.
Okay. So, I mean, I think at this point, we just have to you're going to have to figure out what works within your own practice. And we're doing our best to work with all of you to assure that you do have some supplies on hand, because I'm sure there are times where you don't want to have to evaluate a kid and then send them for a swab if you have the ability to at least do the NP swab on some of the kids. Other questions that were in there, Chad, what else are we missing?
I think you've covered the vast majority of it. I think there's some discussions going back and forth, but I think there's one question that's more of a discussion about at the time a COVID test is negative, sending a note to the school rather than calling the patient or the parents back to try to minimize the number of calls. I think that's just kind of a best practice thing. I don't think there's anything that would prohibit that. If the patient's already been seen and has a COVID test, I don't think there's anything that mandates that there must be another call. So that would be totally legitimate. Several people asking if we can address that. Done and done. The only other thing I saw in there, and I guess, Mike, this is a good question for you just to get once and for all. If a child is sent home with COVID suspected symptoms and they have a sibling, is there any mandate that the sibling has to go through any similar testing or isolation protocol?
No, only the child who's sent home has to go through the protocol.
Perfect.
And so the siblings can return to school. They won't be sent. Okay, great.
Yep.
Big question.
As long as they're symptom free and so forth.
Perfect.
Excellent.
So I think that's really everything for right now, LJ. The only thing I would highlight, there's this whole discussion of, what other tests we could use. I think we have to be attentive to the fact that there's really two issues. There's how can we get the kids back to school as quickly as possible, and how can we minimize the risk of spread of disease when these kids are going to be in close contact. So, if there's a chance that an antigen test may be wrong 1 in 5 times, at least right now, I agree with Brenda. I don't think we're in a position where we'd want to be picking an inferior test just to get the kid back to school faster, when that may mean we expose more kids. So, honestly, even if we tap out on the ability or the capability of the PCR test, we still have the ability to have the discussion about pooled sampling and some of these other modalities, rather than picking an inferior performing test just to try to accomplish the other goal of getting kids back faster. So, I think it's good that we all keep that frame of reference and make sure we're all singing from the same hymnal. So it's not just how do we get them back faster, it's also how do we prevent the spread.
Excellent.
Other than that, I think we're caught up.
Brenda, there's a question on there. I saw one other one, actually 2 other topics, and then we'll move on to talk a little bit about masking. But there's a question there about what's the progress on a saliva test? I'm turning that one to you.
So saliva is, as we think about like specimen types, is the lowest yield, least sensitive specimen type. So again, unless there's some complete reason why a child couldn't get at least a mid-turbinate or nary swab. It's just, it's orders of magnitude less sensitive. So why would we go there if we don't have to? It's also a very difficult specimen to work with in the lab. So these, press about all these rapid saliva tests, it's easy to collect the specimen, but on the lab end, it's actually extremely time intensive. There's nothing rapid about them. So I don't see that as helping throughput on the lab side. And I think for most providers caring for children, getting some sort of nasal swab, for most children, again, should be easy enough. So I think we always, with all these questions, we really have to keep what's our goal in mind. Our goal is to keep our community, and particularly the children in our community, healthy and in school as much as we can.
Excellent. Thank you, Brenda.
LJ, this is Stephen. I'm sorry. I was just saying I'm seeing some more questions come up about the sibling thing. And so just to clarify what Mike said, it sounds like each sibling is considered individual. And if one sibling is sent home, it does not mean the other sibling needs to be sent home. If the one sibling tests positive for COVID, then the quarantine process for the rest of the family and others would follow. But if the sibling tests negative and the other sibling does not have symptoms, then there is no need for anything to happen to that other sibling. I just want to verify that for everybody one more time.
That's correct, Steve. Thank you.
Sure
Perfectly explained, Steve.
Okay.
Steve,
and then,
that's good.
Thanks.
The other
And then,
question that keeps popping up is for kids who have chronic symptoms, whether that's chronic asthma, chronic allergies, that some of the schools are requesting letters stating that, or if they meet some symptoms that are part of the isolation protocol, that they're just chronic conditions for the child, is there an exclusion or way that they can be pre-cleared for that?
So there's a couple of things to that effect I would start with and then turn it over to others. The first is that the screening questions, so the daily screening questions or the questions that would come up at school if a child presented with symptoms. One of the things that we're trying in the schools reopening safely task force is to recommend that the language be the same as what's in the URMC chatbot, the COVID screener in the community, and that would say symptoms that are new or unusual for you. Right off the bat, if the schools are using that screen, that will help tremendously for kids who do have chronic health conditions, who may have daily headaches or may have, chronic cough or rhinorrhea or whatever the case might be for allergies. In addition to that, all of the schools should have a health history form from your practice. And we would just ask for people to be very sensitive to making sure that in that, in the category about current or chronic medical conditions, that those things get listed. It may not have felt as important to list allergic rhinitis before, but it could be important now. And that's not to say you got to go back and redo all of your health history forms. There may need to be some letters generated, but if we can change the screening question and make sure, or amend the screening question so it says symptoms new or unusual for you, that would be, I think, a huge help. And that's what we're.
Amanda just put a comment in that's exactly right, that this should be listed on your health history form, right? In New York State, it's all required that you say asthma or allergies to other things. And so thanks for putting that comment in, Amanda, but hopefully that should be enough. I don't think additional documentation is necessary unless there's a change of symptoms, as you mentioned.
Or if that line item, I mean, I think people should just, glance back at that form. If there's nothing, if it's a blank on that form and that child does have a chronic condition, that needs to be amended. But that would be the better way to do it, even so then it's permanent in the record.
And then the other thought, I thought maybe Ed could provide an update with the new New York State appraisal form. I understand that that's been updated a little bit.
The new form has been updated. It's just a couple of little different boxes. It's not substantially different. It changes some of the things like not having to write down the degree of deviation or of scoliosis and things like that. So it's a little bit better. And for anybody who's on MedDent, they already have that form available as one of their forms. It still has not made it to NICES though, and I don't understand why, because the old new form has been out for over a year, and when you talk to the people at NICES, they haven't even seen the new form. But my understanding is any school form right now any of the New York State school forms are still acceptable.
And that's right. Up through, and Dave Topa just put it in the chat too, January 31st of 2021, the old form is acceptable. We just want to make sure that those forms are accurate and current, especially with any chronic condition.
But while I have the mic for a second, I'm sitting here, what about, I have a lot of kids who like the school nurse. They think she's pretty, they think she's nice, they have anxiety, they have chronic belly aches, they go down once or twice a week with a headache or a bellyache. Based on these, they're going to have to be sent home, and I'm going to have to test them for COVID. And I don't know how many people have done these NP swabs. They're so much worse than flu swabs, and you get even 12-year-olds who are crying and screaming.
Right. Well, Ed, I think that
this
goes back to the issue: is this new or unusual for you? Right? I mean, if they're frequent flyers in the school nurses, the nurses know those kids. And that's why we have to make sure that that is part of the screening protocol, so that we're not just testing, every single kid with every single symptom.
And let's face it, our school nurses and school physicians will have to use a lot of judgment here. And what we've recommended to the school nurses is, ask the kid, 10 minutes later after he or she's been sitting in the nurse's office, so how do you feel now? And to assess. I mean, I think the nurses are good at that. We don't want to over-test, but at the same time, we don't want to lead the witness and say, yeah, sure, your pain is gone. We've got to be careful. But I do think there's going to be a lot of subjectivity on the part of the school nurses.
Although I've heard from school nurses who are being told that anybody who comes down with any of these symptoms gets sent home.
Yeah, that's where a lot of schools are differing. And I think a lot of that has to do with the different levels of risk aversion in different school districts. So, all across the community, we're seeing all across the board as far as how parents feel about how they are wanting their school nurses to operate. So that's a tough one.
So I'm going to move us on from this topic and move on to talking about masking tolerance. And I think that all of you saw the guidance that we put out, that first of all, the Monroe County Department of Public Health has a mask exemption form. The goal of that form was honestly to put an end to people requesting exemptions for all sorts of things that were not necessarily medical, or even if they were medical, not needed. So there were a few things specified on that form, but we also put out some additional language, basically that is in alignment with the American Academy of Pediatrics and with our own developmental behavioral pediatrics experts here, that really, with the exception of children with severe neurologic impairment, where wearing a mask that they would not be able to remove could put them at some risk or danger, that all of our kids deserve to wear a mask, to have the protection from that, and deserve the opportunity to work towards mask tolerance. So I'm not going to speak on that because I'm not the expert. I would like for Lynn Cole to speak to that a little bit, and I would just tell everyone, again, we're going to share out resources, tools tomorrow once we put this together in an email with links. But Lynn and Susan Hyman and the team over at DBP was kind enough to share with us the mask tolerance form that they are completing, the language of that they are completing for schools. And we'll share that with you, that you could just put into your electronic record to use for those kids that you don't want to assume they need the mask exemption, but that you want them to be able to go to school and to work towards mask tolerance. So Lynn, what would you add to that?
So I think, we have been getting an overwhelming number of calls, as I'm sure many offices have been, of parents wanting their child to have a complete mask exemption. And, we've had a lot of discussion around our division around this, and really feel like that, by providing mask exemptions, it is putting our kids with disabilities who are already at risk at higher risk and is increasing the risk to all of their caregivers at school. And so we have really made a blanket statement that we are not providing mask exemption letters, except for what LJ said, if you have, severe cerebral palsy and breathing problems maybe. But that what we're providing is a letter that says some children with, disabilities and sensory differences may need a gradual approach to learning to wear a mask with, reinforcement and sensory interventions and people to work with them. And Karen and Anne, you can speak to this too, but I feel like as a medical provider, it's not my position to designate that, putting people in a school setting at more risk. And that if schools are having, if there's a student at Mary Cariola that somebody wants to have a conversation with us about and work on a plan, that seems fine. But, many of the calls we're getting were from families who just didn't agree with masks in general. And I actually think the families who understand the risk, even those who have children with severe disabilities, have been quite effective in teaching their children to wear masks.
And I think the same is true for very young children also. There's a sense like a young child cannot learn to tolerate a mask, but they actually can. And I want to highlight, because Ed Lewis put it in the chat, the mask toolkit that was put up by DBP is just excellent. We're also circulating a one-pager, Lynn, that highlights the mask toolkit, something especially for parents with young children or children who are having trouble, that just gets the high points, but then refers to the full toolkit. So that is something we'll include tomorrow. I think that, Steve, did you want to add something to Lynn's point and ask a question? Steve Cook?
Yeah, so maybe the point of advocacy is really important. Our own Dr. Susan Hyman somehow got an email to Dr. Zucker's private email, it looks like, and he is very aware of this and wants to make sure this does get addressed because of this being a disparity issue. I got an email this morning from different commissioners in our, through the public health department in Albany. The question about children on the behavioral side seemed okay. The question that came up that I was struggling with, or at least I don't know, I think we are pretty clear in our community, is what about other chronic medical conditions? And as I've looked at and others have talked to a number of our specialists, there's very few medical problems that would meet this threshold. So I was kind of surprised this one Department of Health person had suggested, well, the community docs will have to figure that out. I think we figured out from here, and we've heard from our specialists that, asthma is not an exclusion, congenital heart disease is not an exclusion. So I think there may need to be some push to get this information that we're already talking about here around to the rest of the state. But I'll tell you, Susan Hyman has convinced the commissioner that this is important and needs to be addressed. So we, as LJ was pointing out, we're ahead of the curve compared to many parts of the state. But I think we may want to also clarify that, immune deficiency, cancer treatment, some of those things, do those fall under areas of high risk, but not something of mask exemption? And that's not a document or anything, but there are definitely, as someone pointed out, indications to wear a mask because they're higher risk. And if they're very high risk, maybe they need more remote education, but maybe that's not in our wheelhouse to discuss.
No, and this is Anne, and I'll talk to you about Mary Cariola. The plan there is that all children deserve the right to learn how to wear masks. But what we need here is the opportunity that the first day of school, when they have not yet learned to tolerate the masks, that they be allowed to go on the transportation and not be excluded. And so that's a little bit of a gray area, but our stance is that all children will be worked into a behavioral program to try to teach them to wear masks. And there will be some youngsters that cannot tolerate anything touching their body, even a blood pressure cuff. So I don't think they're going to be wearing masks, but we're going to work toward that goal.
Thank you, Dr. Francis. And I know that you and the team at Mary Cariola have talked about being able to help support the request around the masking tolerance specifically. It helps when Anne Francis is the medical director over there and recognizes how inundated all of you are getting with requests and questions. So it's great to have her at Mary Carroll as the medical director to help support that in terms of the documentation needed. I think that I'm seeing a lot of questions. Adam, do you want to ask your questions? I'm seeing you've got concerns about how you can train someone or concerns from parents about how to train someone to wear a mask.
Hi, sure. Thank you.
Sure.
So with the most severe autistic kiddos who have really struggled to even, like I was saying in my message, I don't know if you saw, but I had one mother crying to me on the phone. I've worked my his entire life to try to get him to wear a winter hat, and I can't even do that. How am I supposed to try to get him to wear a mask? And she, she's feeling kind of very left alone. Like she got a message with the website or the link to the packet, and hey, okay, here you go ahead and do this. And she's feeling kind of left out without really the support that she needs for her son, and feeling kind of left destined for failure, and then is calling me, why won't you do an exemption instead? No one will help my child, et cetera, et cetera. You just partially addressed that in terms of the school having a process for being, accepting that they're not going to come the first day, being able to do that, and the school will work on them to work with them to improve that. But you're coming from that one school. What about all the others? And then is there some type of letter or document that we can provide for those kids who we may not be able to, something in between a mask exemption and just saying we can't provide one at all?
Yes, and that's, I see Joan Flender put an example of one in the chat box, and LJ is going to be sending one out. That's the template that we're using. And so, what I see is that the response I want to give is not, no, this child is never going to be able to wear a mask and we're not going to try, but rather, like Anne said, that this child deserves the opportunity to learn how to wear a mask. The parent, I would not expect a parent by themselves of a very challenging child to be able to accomplish that by themselves before the child goes to school. And so, yes, it's going to be a team effort, and it's going to require work by the parent, by the school team, by the OT, maybe by the behavior team at school. And so, the letter that we're writing is really saying, masking is an important health skill at this point in time, and we would like this child to work towards that goal. The child, because of his disability, may not be able to tolerate a mask for much time to begin with, but that we expect that with the right support over time that will improve.
Thank you very much. And I agree completely. Of course, the parents' response is, well, they're going to be spending so much time trying to get him to wear a mask, and I don't see that being possible, that they're going to be spending his entire education trying to get him to wear a mask. And she's also then concerned that he's not going to be able to communicate the fact that he is feeling short of breath. He is having trouble breathing, and he wants to take off his mask. He's not going to be able to communicate that if it's kind of being forced. I'm just forwarding her concerns as an example, but I agree. I understand. Thank you very much for your response.
I think you have echoed the concerns of a number of our providers and the types of questions that everyone is getting. But I think it is our responsibility to really emphasize, because I really think our community is not getting this, how important masking is, how important the physical distance is, that it's a responsibility that we all have, and that we're teaching our kids, right? I mean, that's what we teach. We don't expect them to just grasp something the first time.
And I do think
I'm sorry, our schools have the same message. This is the thing that I wanted to make sure that people knew. So thanks to the work of the reopening task force, the Finger Lakes Reopening Task Force, and our County Department of Health, the schools have the same guidance. The schools have the same information about mask tolerance. The schools have the same protocols that you're needing to follow from the County Department of Health. And as I said at the beginning of the call, all of that guidance, whatever's coming from the County Department of Health or whatever is coming out as a support from the Finger Lakes Task Force is being sent now at the same time, on the same day, to the schools and to the healthcare providers. So we are not at cross purposes. And we will make sure if any of the guidance changes or as our situation in the community changes, that you get updates in real time exactly at the same time as the schools are. And I think that's a really important thing. I'm going to move on from mask tolerance. We could spend a lot of time on that, but there's a very pressing issue that I think everyone on the call needs to understand. So I'm making you stick around for an extra 5 minutes. And that is, sorry. Oh, great. My screen is going to freeze on me. Sorry. Hold on one second. Okay. There it is. We need to be putting, not that we haven't already been putting, but we need to put a full court press priority on vaccination catch up for kids who are behind. And I want to explain this. Like, I really want to commend everybody. I said this on our last call. Our rates of immunization are so much better than so many all around the state because you all worked so hard to prioritize kids for in-person visits with vaccines in mind. But state DOH guidance was just released that states that children must receive any overdue doses of vaccines within 14 days after school resumes. And here's the key thing in that message. That's regardless of in-person or remote learning. So I am sure that most of you, like me, or others of us, assumed that now we had, at least for our kids in RCSD or for kids who are going to be remote learning, we had some catch-up time. We might have 10 weeks before we had to have all of those vaccines caught up. But what it is saying, what this guidance states, and it's extremely explicit, is that it's remote learning or otherwise. So what that means for kids, I'm just going to use RCSD as an example. Within 2 weeks of remote learning start, those kids will be technically not allowed to participate, which I just can't even say. It makes no sense whatsoever. I think it's a huge opportunity for advocacy. I think, I know that Dr. Mendoza and his team have been very good about highlighting concerns. That's a different than advocacy, but I think for the rest of us, this is a real moment for advocacy. We need that time because we need to be doing flu vaccines and catching up on immunizations, right? And needed screenings. I mean, those kids in our CSD have not seen anybody for over 6 months. We don't even know where they are in terms of their developmental assessments, their school screenings. We have a real opportunity for those of you who care for kids in our CSD to do something different this year, to really partner with the schools, with the school nurses that are still available. We'd like to hold a separate meeting next week to talk about this with the practices who have care for the predominant number of kids within the city school district. But this isn't, I'm using our CSD as an example because to me it's a stark example of what this would do. And the inequity, that makes no sense. And I think that we have to work on that. But this is true for any kids who are in remote learning. So that's not just our CSD, I realize. So we have to be cognizant that hopefully we can get an extension on this. But in the meantime, if you're not already still prioritizing those kids who are behind in vaccinations, it's a great time to run your lists. Check your EMR records and be doing some calling to get those kids in for their immunizations and if they're behind in their well care visits. And I say that knowing full well from hearing from so many of you that you are working like crazy hours right now. You're doing Saturday or Sunday visits to get in well care visits plus illness. You're doing evening hours. So anything that we can do to support this on a community level without siloing it from the medical home, because I think that's the worst thing we can do many times is pull this stuff off and then not have it connect to the medical home or to your practices. We should be able to figure out a plan, but we've got some serious work to do in that space. And I just learned about this about 3 hours ago before the meeting. I don't know if Mike has anything to add to that or if anyone else wants to comment.
LJ, since this is Department of Health, do you have people that we can, I mean, I'm willing to send a letter out to the upstate AAP members, but
I was
it would
hoping to
help if
say
we
that.
had somebody that we could call or email.
Yeah, so I just got the actual letter emailed to me, and we put out some inquiries to find out where do we need to elevate this. So if I can get you some names, Ed, and I'm thinking Chris Bell with, you know, AAP and Monroe County Medical Society and others, if we can really push on this. It does not make sense, and I mean, it just widens the divide.
Yeah, I would think we should start with Betsy Rausch-Fung at the Bureau of Immunization at DOH. She's
So
really
Chris,
a great contact for
Chris,
that.
if I
know her
forward,
well.
Chris, you're good at this. You and Ed, can you guys champion this?
Yes.
Can I send you the letter and have you guys take that and run with it?
Yes.
Sweet. Okay, awesome.
Great.
All right,
Thank you.
You're welcome. No, thank you. So stopping my share screen again to see all your faces. Was there anything else that's pressing in the chat?
LJ, one thing I saw come up earlier that I have a question about too is, do schools require a letter for a patient that wants to do remote learning? My understanding was that they can just choose to do that as a parent or a family without any input. But
That's absolutely right.
I've received several requests, and I saw in the chat some people were asking about that as well. So
thank you for highlighting that, Stephen. No, there is no need for a medical excuse for remote learning at all. That's a parent choice. Other things?
Yeah, LJ, there's one question that's gotten sent to me privately and I think was in the chat earlier. The protocol for parents who refuse COVID testing for their child. So they get sent home with symptoms. They are supposed to have a COVID test negative to return, but they refuse. Is the 10 days sufficient if they're symptom free? And if so, everybody and their mother is probably going to opt for 10 days and not get testing in some cases. So I just put that out there.
So currently the schools are not allowed to accept the 10 days in lieu of a test or 14 days in lieu of a test. The schools are being told that they need to have a test, which, as you can imagine, that's going to create some issues. So we're looking into whether there are alternatives to the testing, but for now it's still required.
Thank you.
LJ, lots of questions about daycare. Any idea when folks can anticipate guidance for daycare?
So there is guidance for daycare, but it's that my understanding is it's OCFS and it's less regulated than what the DOH guidelines are. And so, I mean, I think that at this point in time, State Ed, OCFS, and DOH all have slightly different guidelines. And so I think at this point, I think we are hoping that there will be some kind of alignment, but I don't know if we want the alignment to be so strict as what we're fighting against right now with DOH guidance. So I hope as DOH begins to lift a few of these things that Mike talked about, we might be closer and then be able to get something. I do know that there is a lot of work right now to try to standardize some things across the child care centers. And a lot of that work's being done sort of at a system integration level. I don't think that the Finger Lakes Task Force has embraced that because honestly, they're really just focused on preschool and school. So I just want to add one more thing. So Larry Dank, I loved your message. Are you the only one who thinks that kids should get their vaccines within 2 weeks? It's something. The reason why I worry about that, Larry, is not because it's not a good thing. We do want these kids to get their vaccines absolutely, but 4 weeks or a little more would be helpful, because I'm not sure if folks are aware, but RCSD is laying off half of their nurses. So at this point in time right now, the system that was in place been able to get into the practice of be seen. That's 18 is the Monroe County Department of Public Health, who used to do walk-in vaccination clinics, but cannot right now. They can do appointments, but they're not getting the same numbers for appointments. And the other thing is, the school nurses used to help with a lot of that. And now we've got, 3 or 4 schools with 1 school nurse. I mean, they are not going to have the staffing So we need a little bit of extension, but amen. We want to get those kids get their vaccines. I don't mean to extend it for a year, but how bad is it if a parent cannot have their child participate in any kind of remote learning because there's a barrier put up and they can't get in to get that vaccine? And that is a concern that was expressed specifically from teams within RCSD who have been responsible for this in the past, who thought there was going to be at least some extension, and now know that they're going to be doing this with less person power than they used to have.
Right. So I see. So you mean like the nurses wouldn't have time to even go through all their students to see?
They can't even, they have not been able to go through and identify who needs those vaccines. So as they're doing it, it's so far behind. I mean, we need to do it. I think we could do it together. I think we could do something really innovative that would be better than maybe we've ever done before, and we learn from it. But we do need more than 2 weeks to get it done. But we got to get done as much as we can in 2 weeks right now.
And LJ, we're also dealing with this HHS exemption now, saying that pharmacists can give standard vaccines to 3 to 18-year-olds. So when you mentioned that we need to make sure that we keep this in the medical home, I think that's a good point. So we need, if we have a little bit more leeway when these kids can be identified and not have to get them in the first 2 weeks of school, it keeps it in the medical home. And we can argue with the federal government that we need to keep it that way.
And I guess the other thing I would just say, like really thinking about this, if you're going to be able to catch kids once, don't we want to make sure that we can be doing flu vaccine at the same time? Like, let's be smart and let's be prepared and be doing both, whether it's in our practices or whether it's in the community. And I recognize for every kid, it's not going to be able to be in the medical home, but it can be linked. If it's linked to the medical home, that's a different story. And that's not something that we've traditionally done before. It's been very separate. So,
LJ, I see people also mentioning about the 6 feet or masks in multiple places that some schools are allowing for that. I think we can revisit that with our task force and make sure that people know, again, that the ideal is 6 feet and masks with occasional breaks. So
yes, exactly. Yes, Stephen, we can take that back to the task force and make sure that message is being reinforced. It's very important.
Mike, I saw one question. If a kid is seen in the office and they're positive, what about the staff that sees them? I mean, it would be a potential exposure, it would be time, but I assume that the county would, I mean, they would take care of contact tracing. That would include any of the staff either at the school or the staff in the medical office who saw them as well.
Yeah, that would be a scenario that we're pretty familiar with, unfortunately. So we would do the contact tracing, and everybody in healthcare has been very vigilant about wearing their PPE. So in general, most healthcare workers are not going to be excluded because they've been using protection.
And we've just designed PPE guidance for the schools, for staff in the schools, about what they should be utilizing for the nursing staff who would be doing medical evaluations so that they're protected, as well as for any other teaching staff that might be working with a child who would need more than just face covering.
So one more point on that, an area where we are different from the CDC. The CDC, for the purposes of defining a close contact, they do not consider mask wearing in that equation. They just say that if you've been 6 feet or less for 15 minutes or more, you're a close contact. Here in Monroe County, we've decided that wearing a mask does protect you. And so if you are wearing your mask consistently, in spite of 6 feet or closer for 15 minutes or longer, we will generally not require quarantine in that case. So that is an area where we differ locally from the CDC.
Mike, is that any mask, including the ones that are supposed to make matters worse?
Well, there's a lot of debate about if masks make matters worse. We're discouraging, and I know the schools are not permitting the gaiters and the bandanas and those things. They're also not permitting, and we're in fact discouraging the masks that have the valve. All those things are off limits. We're just saying the straight up face coverings or the ear loop surgical masks. So yeah.
And Mike, for a little clarification on that as well, is that both people, the person that ends up, say if it's a student that's positive, also would have to be masked, or just if as the staff member or whomever, as long as you have the mask on?
That's where we have to dig in a little bit, because there's often a lot of confusion about the masks, and frankly, sometimes we don't believe people.
Yeah, so maybe the message is that the safest, obviously the best measure of safest is that everyone wears the mask,
Yes.
but that even, as people are trying to figure out what defines exposure, that,
I will say that our experience in Pittsford over the weekend with these 17-year-olds tells us that 17-year-olds are highly motivated to protect their friends. So there's a lot of confusion as to what actually happened in Pittsburgh.
Bitches get stitches, right?
Right.
All right. Have I missed anything else that's a critical moment here? Chad, anything else in that chat? From any of our speakers, any last comment? We kept everybody 15 minutes later. And so any last comments you want to make? I'm hearing silence. So I would say, oops, sorry.
just to say thanks, everyone. It's really a pleasure to work in such an amazing community.
Yeah, so last time I closed by saying I'm really proud and happy that I'm in Rochester, which I am, and I'm going to say game on. All right, we're going to play this game with the cards we have. We're going to get better cards, and we're going to play it together. So please keep sending your questions through emails. We will release an email with links later in the day tomorrow, and then obviously update you as we hear anything different from Mike and the team at the county. And I thank Monroe County Medical Society and the AAP chapter for taking on that advocacy challenge for our kids. All right, you guys, have a good night. Thank you.
Night all. Thanks.
Good night.
Bye.